Hello, everyone. Thank you for joining the IBPF webinar today. I am very pleased to introduce Dr. Heather MacPherson, who will discuss with us the development, onset, and course of bipolar disorder in children and adolescents. In addition, she will discuss current evidence-based treatments and specifically child and family-focused cognitive behavioral therapy, also called rainbow therapy. Dr. MacPherson is a postdoctoral fellow in the Department of Psychology at Harvard University. She earned her BA in psychology from Boston University and her MA and PhD in clinical psychology from the Ohio State University. She completed her pre-doctoral internship at the University of Illinois at Chicago Department of Psychiatry. She is primarily interested in evaluating interventions for children and adolescents with mood dysregulation and identifying mechanisms of change. She has published numerous articles and chapters on this topic and also presented her work at national conferences. Welcome, Dr. MacPherson. We're very happy to have you today.
Well, thank you so much for the opportunity to speak today. I want to start off by providing a brief background just to supplement what you said. I am a clinical psychologist and specialize in the assessment and treatment of pediatric mood disorders. And specifically, I work with children and families affected by depression and bipolar disorder and study psychosocial treatments for this population to help children and families manage mood symptoms and increase their psychosocial functioning and quality of life. I'm currently a postdoctoral fellow at Harvard University and had the opportunity to work and collaborate with Amy West, Sally Weinstein, and Mani Pavoluri and colleagues at the University of Illinois at Chicago, where child and family-focused cognitive behavioral therapy, or rainbow therapy, was developed. My goal for today is to offer providers, parents, and others listening with information about bipolar disorder in children and review psychosocial treatment strategies that can help ameliorate mood symptoms in youth. And so before we get started, I just wanted to thank the International Bipolar Foundation for having me and for providing me with the opportunity to speak with all of you about bipolar disorder in children. And so today, I'll provide an overview of the symptoms of pediatric bipolar disorder and how it's diagnosed, discuss how to recognize mood symptoms in children, and then talk about rainbow therapy and offer some specific psychosocial strategies and tools that we've found helpful in working with children with pediatric bipolar disorder and their families. So first, I want to talk about the spectrum of mood symptoms that children can experience. Mood symptoms exist along a spectrum ranging from severe depression to extreme mania, with various levels in between. Bipolar 1 disorder describes patients who have experienced a manic episode and often also a major depressive episode. Bipolar 2 disorder describes patients who have experienced a major depressive episode and hypomania, but have not experienced a full manic episode. These individuals may have experienced some symptoms of mania, but they were never intense or long-lasting enough to be considered a full episode. Of note, bipolar 2 disorder is relatively rare in children. Cyclothymia describes patients who experience depressive and hypomanic symptoms, but none that meet criteria for a full depressive, manic, or hypomanic episode. Finally, when children are experiencing some symptoms of depression and some symptoms of mania, but do not meet the formal diagnostic criteria for full mood episodes or other higher order bipolar disorders, they are often diagnosed with unspecified bipolar disorder. Unspecified bipolar disorder is very common in children, and we'll talk about why in a few slides. Most children who are diagnosed with bipolar disorder are diagnosed with either bipolar 1 disorder or unspecified bipolar disorder. For a long time, there was a myth that children could not have bipolar disorder. Unfortunately, this led to many children being misdiagnosed and inadequately treated. We now know that children can indeed be diagnosed with bipolar disorder. In fact, recent international epidemiological data suggests that 1% of children experience bipolar disorder and up to 13% experience subthreshold symptoms that are still very impairing. This has led psychologists and other researchers to begin to develop and research effective treatments. Pediatric mania is diagnosed when a certain cluster of symptoms are present. First, the child must experience elevated or irritable mood with increased energy. We'll see some examples of what that might look like on the next slide. In addition to this mood state, the child must also experience at least 3 or 4 other symptoms of mania, depending on the primary mood disturbance. Grandiosity means demonstrating an inflated sense of self and abilities. For example, children may describe having superpowers or consistently talk and act like they are smarter, more athletic, or better than everyone else. Constant goal-directed activity describes when children become obsessed with games or other activities and have trouble stopping or slowing down. Involvement in excessive pleasurable or risky activities occurs when children excessively and inappropriately engage in pleasurable activities which may have negative consequences. This can manifest as hypersexuality, with children inappropriately touching, making advances, or masturbating, or this could entail children acting like daredevils, such as going off very risky or dangerous skateboard ramps, which may be out of character for the child when not in a mood episode. Children can also be highly distractible and have difficulty concentrating. Parents may describe them as hyperactive, all over the place, and bouncing off the walls. Decreased need for sleep occurs when children appear to have very little need for sleep. They may sleep 2 to 4 hours per night and not seem tired the next day. Parents may find them watching TV, engaging in activities, or playing video games in the middle of the night. Flight of ideas occurs when children feel like their thoughts are going so fast that they can't turn them off. This is often described as racing thoughts. Racing thoughts can result in pressured speech, which means that children talk loudly and rapidly, sometimes almost spitting out their words. Others may describe them as difficult to understand or follow. What is most important to consider is the intensity and episodicity of symptoms. All parents can probably provide examples of their children engaging in behaviors I just described. For example, children tend to be a little grandiose, have a lot of energy, and get really excited sometimes, etc. In many ways, mania is just an extreme version of normative behaviors. The key to determining whether a child may be experiencing clinically significant mania is to assess whether these symptoms occur simultaneously, represent a distinct difference from the child's normal functioning, and cause distress or impairment. In order to diagnose mania, these symptoms must reach a certain threshold for severity and intensity, last at least 1 week, represent a change from previous functioning, and cause significant impairment in the child's functioning, such as difficulty at school or getting along with others. The diagnosis of mania requires either expansive or irritable mood with increased energy. Here are some examples of what expansive or irritable mood might look like in children. Expansive mood usually manifests as extreme, over-the-top excitement. When experiencing this mood, children often act very silly and giggly in ways that are out of proportion to the situation. They will also joke perpetually and inappropriately, be on the go, and feel invincible. Parents and others often describe children as exhausting and overwhelming to be around when they're in this state. When experiencing an irritable mood, children are usually aggressive, abrasive, and hostile. They'll be very quick to anger, and their angry responses will be intense and extreme. They'll often scream, curse, and threaten. They may also become physically aggressive, such as throwing furniture or kicking through walls. In addition, their reactions are out of proportion to the situation or trigger. For example, having a 2-hour rage episode in response to finding out that their favorite TV show was not on that night. Parents often describe their children as intense and inconsolable when they're in this state. I also want to take a moment to further discuss the rage episodes that are associated with pediatric bipolar disorder. Rage episodes are common and often the primary reason parents seek treatment for their children. I often get asked how rage episodes in the context of bipolar disorder are different from regular temper tantrums. It's hard to describe unless you've witnessed one, but essentially, the difference is in intensity and length. These rages are incredibly intense and extreme, with excruciating crying and screaming and often verbal and physical aggression. They may last for an hour or more, during which the child is inconsolable and experiences other simultaneous symptoms of mania. When you see a child having one of these rage episodes, you sense that this child has truly lost control and has no ability to modulate their emotions in that moment. Afterwards, these children will often be very sorry and remorseful and talk about how they lost control of their brain or a monster took over. In addition to mania, children with bipolar disorder also frequently present with depressive symptoms and episodes. Major depressive episodes require a 2-week period of depressed mood, either sadness or irritability most of the day, nearly every day, or anhedonia, which is a diminished interest in activities that used to be enjoyable, like a child all of a sudden not wanting to play soccer or to be in the band when that used to be one of their most favorite things to do. 5 or more additional symptoms must co-occur with the mood disturbance, including significant weight loss or gain, an increase or decrease in appetite, sleeping too little or too much, psychomotor agitation or retardation, meaning their body movements are either faster or slower than usual, fatigue or loss of energy, feelings of worthlessness or guilt, which are often associated with negative thoughts, diminished concentration and trouble making decisions, and recurrent thoughts of death or suicidal thoughts and behavior. Again, it's important to note that these behaviors must occur simultaneously with the mood disturbance, represent a significant change in functioning, and cause functional impairment. When thinking about effective treatment for pediatric bipolar disorder, it's important to understand the science underlying the unique characteristics of pediatric bipolar disorder, neural or brain changes that might contribute to symptoms, and psychosocial and interpersonal difficulties that accompany mood dysregulation. Part of the reason that there's been so much controversy and misunderstanding surrounding pediatric bipolar disorder is because it tends to look a little bit different from bipolar disorder in adults. These are a few of the characteristics that are unique to bipolar disorder in children, though we don't know why the disorder presents differently. It may have something to do with developmental manifestations of symptoms, different stages of brain development, or having fewer cognitive abilities and coping skills in childhood. It's also important that when mood dysregulation associated with bipolar disorder occurs in childhood, it may involve different pathways in the brain that result in slightly different symptoms. Children with bipolar disorder tend to exhibit extreme mood lability. Their mood may fluctuate from irritable, excitable, impulsive, intrusive, and loud, to sullen, withdrawn, and weepy, all within the course of a day. Parents will often describe children as very moody. We talked about rage episodes, which tend to be unique to pediatric bipolar disorder compared to adult onset bipolar disorder. Children tend to cycle between symptoms of mania and symptoms of depression multiple times per day. This is called rapid cycling and is much more common in children compared to adults with bipolar disorder. As a result of this rapid cycling, children can also exhibit symptoms of depression and mania at the same time. For example, they may describe feeling worthless and sad, while also appearing irritable, energetic, hypersexual, and impulsive. Finally, children with bipolar disorder often meet criteria for multiple other disorders, including ADHD, ODD, and anxiety. It's often the case that children get diagnosed with these disorders first, and only after treatment fails does an underlying bipolar disorder get diagnosed. This complication and some overlapping symptoms across these disorders is what makes accurate diagnosis of bipolar disorder in children so tricky. Neuroscience, or brain science, is a rapidly growing field. fMRI and other technologies allow us to examine the brains of children with bipolar disorder and the brains of children without bipolar disorder while they engage in different computerized tasks. This helps us better understand how the brains of children with bipolar disorder might work differently. The science is quite complicated, but essentially, one thing we know is that the areas of the brain related to problem solving, like the prefrontal cortex, tend to be underactivated, and the areas of the brain related to emotions and affect regulation, like the amygdala, tend to be overactivated. Thus, when faced with any sort of emotionally charged event, children with bipolar disorder exhibit decreased problem solving and excessive emotionality. This might help explain rage responses, mood swings, and psychosocial impairments observed in these children. Finally, we know that children with bipolar disorder experience many interpersonal and environmental stressors associated with symptoms of mania and depression. These include peer rejection, conflict in the family, low self-esteem and feelings of worthlessness, exhaustion and strain in parents, and problems with school and academic functioning. Before I jump into describing the rainbow treatment developed at UIC and some of the therapeutic strategies that can be helpful, I want to emphasize why psychosocial intervention, in addition to medication, is important when treating pediatric bipolar disorder. First, there are many psychosocial impairments associated with mood symptoms, listed on this and the prior slide. We also know that while medication may help stabilize mania and depression, it will not directly address psychosocial issues, which are associated with onset and course of the disorder. In addition, medication treatment is complicated by high rates of non-response and many negative side effects. Therefore, psychosocial intervention is considered a necessary component of treatment and should be delivered by someone with experience and specialty in treating pediatric mood disorders. Although adjunctive psychotherapy is recognized as an important treatment component by the American Academy of Child and Adolescent Psychiatry, few psychosocial treatments for bipolar disorder in children have been developed and rigorously studied. There are only a handful, and the Rainbow program is one of them. Research has highlighted some important elements common across current treatments for this population, including working with the whole family system as opposed to just the child, and incorporating education about bipolar disorder, cognitive behavioral therapy, and interpersonal psychotherapy. Thus, treatment should focus on educating the family, addressing maladaptive thoughts and feelings in a structured way, and building affect regulation and interpersonal coping skills. Importantly, treatment should also focus on other systems relevant to the child and family, such as schools and the community. Rainbow, also called Child and Family Focused Cognitive Behavioral Therapy, is a treatment that was developed at UIC by Amy West, Sally Weinstein, and Mani Pavoluri and colleagues for children ages 7 to 13 with bipolar spectrum disorders. The acronym RAINBOW indicates 7 core ingredients important in treating pediatric bipolar disorder. These include routine, affect control, I can do it, no negative thoughts and live in the now, be a good friend and balanced lifestyle, oh, how can we solve it, and ways to get support. Now, I'm going to talk through each of these components and offer examples of strategies and interventions that could be helpful if you are working or have a child with bipolar disorder, moodiness, or emotion dysregulation. Starting with R of Rainbow, which stands for routine, we know that children with bipolar disorder experience severe mood dysregulation, and evidence has shown that disturbances in routine or lack of structure can trigger or intensify dysregulation. So, the goal of this component is to improve affect regulation and decrease symptoms through establishing predictable, simple routines for children and families. Some specific routines may involve making predictable routines around sleeping, diet, medication, and transitions. For example, children should go to bed and wake up at the same time every day. This helps regulate all of their bodily processes, including emotion regulation. Children and parents can create sleep diaries or charts to track sleep and work towards a good routine. In addition, we found that adding soothing and release activities into the child's routine every day can be helpful. Soothing activities are activities that are designed to soothe the child's nervous system, like listening to soothing music, taking a bath, or reading with a parent. Release activities are activities that are designed to help children burn off excess energy, such as playing sports, going for a walk, or playing at the playground. It can be important for parents to find ways to make these routines predictable and consistent. They can use posted reminders of the routine, give warnings to help children anticipate transitions or changes, and plan ahead to avoid routine disruptions. The second component of Rainbow focuses on affect regulation, which is grounded in what we know about brain functioning in pediatric bipolar disorder and difficulties with mood regulation. The goal is to help develop appropriate behavioral management and coping strategies to compensate for these difficulties. Treatment focuses on, first, helping children understand their feelings and how they relate to the brain. It is also important to provide education to families about the biological underpinnings of the disorder so that parents understand that this is a brain disorder, not just their child being purposefully and willfully difficult. This knowledge can help change negative family perceptions and dynamics around managing difficulties. In addition, self-monitoring of moods is a very important skill. On this slide is an example of a mood monitoring form that allows children to rate their mood each day using different colors. Finally, it is important to develop coping skills to prevent and manage difficulties as they arise. Parents can work with their children and therapists to design coping plans for various triggers. Common triggers include siblings, homework, and being told no. Once triggers are identified, the family and therapist can work together to develop step-by-step plans for what parents and children can do to cope in these situations. Families can also develop coping plans for rage storms. For parents, this might include a step-by-step plan where they remind themselves about the biological difficulties their child is facing, try to remain neutral, and help soothe and de-escalate the child, as opposed to engaging in behaviors that could make the rage worse, like excessive punishment, yelling, or threatening. It can be helpful to conceptualize this process as putting out the fire. During these episodes, we want parents and families to pour water on the fire through soothing and coping versus fanning the flames by yelling and arguing. This is a great example of one coping strategy developed by a family in the Rainbow program. This child created a cool-down corner in her room. She called it Sam's Snow Cone Corner and equipped it with a list of coping strategies, soothing images, and favorite toys. When she began to get upset, she would go to her corner and use these strategies to soothe herself and help cope with whatever intense affect she was experiencing. I in Rainbow stands for I can do it and focuses on self-esteem. Evidence suggests that self-efficacy plays an important role in the management of mood episodes. In addition, children with bipolar disorder often present with very low self-esteem. So, the goal of this component is to increase the family's belief in their ability to cope with the disorder and also improve self-concept. Here, we draw on more traditional CBT techniques as well as mindfulness approaches to parenting. Specifically, we teach parents how to recognize their child's strengths, find opportunities for success mastery experiences for their child, provide consistent positive reinforcement, and develop their own positive mantras about their ability to cope. In addition, we help children identify their positive qualities, which can be quite challenging for these kids, establish an identity that is separate from their symptoms or disorder, and develop positive scripts and skills to manage stressors. N in Rainbow has double meaning: no negative thoughts and live in the now. We know that mood disorders are associated with negative or distorted thoughts and beliefs about the self, others, and the future. The goals of this component are twofold. The first is to decrease negative thinking patterns in both children and parents. The second goal draws again on mindfulness and encourages a focus on coping in the present moment to avoid becoming overwhelmed by thoughts of the past or future. This part of treatment involves more traditional CBT approaches for recognizing and reframing negative thoughts, which can increase distress, along with mindfulness techniques for parents. Mindfulness techniques help parents focus on the present moment through breathing and non-judgmental acceptance of thoughts and emotions. In addition, we have parents practice approaching their child with calmness and compassion by building empathy, taking the child's perspective, and bringing their full attention to situations. These skills can help prevent parents from feeling overwhelmed and facilitate their ability to effectively cope with their child's difficulties. Parents can be reminded to use these skills through the use of mantras, which can help them remain calm and attentive to the present moment. B is again a two-part component. As previously discussed, children with pediatric bipolar disorder often have significant social difficulties. So the first goal is to improve social functioning in children. Also, parents often experience their own stress and strain. So the second goal is to enhance parental self-care and balance in their lives. These goals are addressed through work with both the parent and child. With the child, we focus on developing skills for making friends and communicating effectively with others. Parents are encouraged to seek opportunities for their child to practice skills and develop friendships. In addition, parents are encouraged to find a healthier balance between the demands of caring for a child with bipolar disorder and taking care of themselves by making sure to build in time for friends, exercise, pleasurable activities, etc. This is an example of an activity we do with parents to achieve a more balanced lifestyle. We have them complete two pie charts. The first describes their actual time spent doing different activities like chores, childcare, and errands, and the second describes their ideal allocation of time. Then we work with them to find ways to redistribute how they allocate their time to improve balance and enhance self-care. The next component focuses on building problem-solving skills in the child and family. As we know, these skills are impaired in these youth and these families, and they tend to experience much stress and conflict. As part of this component, children are taught problem-solving skills and how to apply coping skills to new situations. We also work with the family, including siblings, on positive communication and problem solving. One of the most important things to remember with regards to problem solving is the timing and tone of these interactions. We help parents try new ways of problem solving that involve discussing difficulties during calm periods rather than in the heat of the moment. We also emphasize using a collaborative, empathic approach to problem solving that involves being proactive versus reactive to difficult situations. The family bug box is one strategy that's worked well for families. We have families create a box that's located somewhere centrally, like in the kitchen. Throughout the week, parents and children are encouraged to put pieces of paper into the box that describe triggers they experienced that week, or things that bugged them or upset them. At the end of the week, the family sits down together and goes through each scenario and tries to problem solve resolutions for those triggers or situations so that they have a plan if these things occur again. And finally, it's very important to focus on ways to seek support, as stigma, isolation, and lack of access may prevent families from finding or using support networks. So the goal of this component is to increase access to support systems for the child and family, and teach parents how to be an effective advocate for their child at school. We have both parents and children complete a support tree to identify positive sources of support in the various systems of their lives, like at school, socially, and within the family. Support trees serve as a great visual reminder of people in support networks. Lastly, school consultation is vital since children spend the majority of their time at school. Therapists and parents can work with school personnel to educate them about bipolar disorder in children, ensure that there are appropriate adaptations and supports in place to deal with emotional or learning issues, and facilitate open communication between parents and the school. So in conclusion, my goal for today was to provide education about how to recognize bipolar disorder in children and offer some useful tools and strategies to address symptoms. If you believe your child may have bipolar disorder, or if your child has any sort of emotion regulation difficulties, whether or not it is bipolar disorder, it is important to seek out a clinic or therapist who specializes in or has experience treating pediatric mood disorders. If such a clinician or agency does not exist in your area, we would encourage families to seek providers using evidence-based practices, such as CBT. The American Psychological Association's Division 53, the Society of Clinical Clinical Child and Adolescent Psychology, has a helpful website for learning more about evidence-based treatments, which is displayed at the bottom of this slide. Finally, the Rainbow Treatment Manual should be in print later this year through Oxford University Press, so providers can be on the lookout for this if they're interested in learning more about how to treat bipolar disorder in children using this approach. At the end of the day, children with bipolar disorder and their families need the same things that we all need when facing difficulties or challenges in life. They need education, support, and understanding, in addition to tools, strategies, and resources. Most of all, they need encouragement and hope that there is help available. Pediatric bipolar disorder and mood difficulties in children are a real thing with a real underlying biology. It's no one's fault. Children are not at fault because they have difficulty regulating their emotions, and parents are not bad or incompetent because they don't know what to do. Luckily, we have good treatments that can help children and families manage these symptoms and impairments and restore peace and balance in the family system. With that, I'd like to thank everyone listening today and the International Bipolar Foundation for having me, and I'll stop there, and I'm happy to answer any questions.
Excellent. Thank you, Heather, for that very insightful presentation. As Heather has said, she's open for questions, and know it takes a few minutes to those typing fingers working this morning. I just want to remind everyone that this presentation has been recorded and will be archived on our website at ibpf.org for further viewing or sharing with others. And also, in addition, if you have questions that you may think of after this webinar has completed, please feel free to email me at dbrown@ibpf.org, and I'd be happy to share those with Heather. It looks like we don't have any questions this morning, Heather. So thank you again, very much appreciated, and happy that this will be on our website for future reference and to share with others. Everyone have a great day, and we hope to see you at our next webinar.
Thank you.